business of allied health. But so I'd seen him a lot from Facebook paid ads from him and stuff. So I've known Todd for a while. He supported us in our early startup around email marketing for newsletters with his business, very successful business coaching for Scale My Clinic with Sachin. And it's just been a very well-respected GP industry lead, actually, with I haven't seen anything negative about it around that. And he's got a lot of experience in entrepreneurship. So he started Modern Healthcare.
Modern Medical, yep.
Actually, we rented a room from you guys in Dandenong many years ago. And then he sold it out to Zenitas and he became a director at the ASX level. So he follows a bit of similar path to someone like Jason Smith in our industry, ran Back in Motion.
Yeah.
Well, and then he also runs lots of startups. He's got GP Hero, which is outsourced admin service.
Yep.
I think he just sold his clinics. So 3 weeks ago. So I'd love to hear your insights there, and really thankful that he's here. And the great thing is he's not practicing, so he can say things that you may not hear other GPs say about this. So what I wanted to pick his brains is today, around his own story, because I think others can derive, lessons from that as business owners and other physios and other allied health, and just some sticky questions around what GPs thinks of physios and the others. Welcome, Todd.
Thanks, Barry. That's quite the intro.
Interesting one. I haven't heard that one for a while, but I'm completely made up there. But yeah. So yeah, tell us about your story. How did you end up starting?
Sure.
Up in business. Yeah.
Yeah. So when I was growing up, my dad I won't take you back too far, but my dad was in insurance and unfortunately died when I was relatively young. I was 14 when he died, but coming up to that time, he was in a coaching thing in insurance sales. He used to go to something called the $1 Million Round Table. Anyway, he'd get a whole bunch of books and stuff that came with that. All of the stuff from that era, Zig Ziglar, Jim Rohn, all of these famous authors. Anyway, we had all these books at home, and I really love reading. And, we hadn't invented things to distract us as much as in the modern era. And so I read all these books as a young kid. I was probably somewhere between 8 and 13 reading all these books. And at the time, they really interested me. And I used to have those, remember you get the cassette tapes in the big plastic folder that you would unpeel it. You could take about one at a time. Anyway, I'd listen to all these tapes, read the books. It was only later on I realized that I don't reckon my dad ever read any of these things. And it was meant for him. But later on in life, I think that stuff kind of influenced me. And then I thought, you know what, when I graduated medicine, I did a year of physician training. I wasn't very good at kissing asses, which was required in hospitals. And so I decided that hospitals weren't really for me. I did a year of physician training and thought, I'm leaving. I went and did a year in the UK because I wasn't quite sure what I wanted to do. And then I decided that general practice was really where I wanted to be, because I kind of figured that all of the cool patients were kept out of hospital. The real work was keeping people out of hospitals, and community medicine was where it was at. And then the other part I really liked about it was unreferred service delivery. And so you could build an actual business out of that. And I really liked the idea, having worked in a hospital, it really pissed me off that you couldn't choose who you worked with. You couldn't build any particular systems or processes. It was kind of, like the model for teaching anything was see one, do one, teach one was the kind of model that everybody went with. It wasn't particularly good. It got people to where they did, but there was just a lot of things in the system that meant that you really couldn't get high quality, reliable team output. And that just kind of really annoyed me. And so I thought, look, I'm not really interested in trying to change the hospital system and structure, which is very hierarchical. I had 2 people I worked with on their unit tell me they would see to it that I never got a job in their profession. Shout out to vascular surgery and psychiatry. So I thought, you know what, I want to build a business where I'm going to do the things that I think are important. I want to recruit awesome people, build great teams, put together solid processes, and have a great experience for patients. And so the first time I did that myself was in 2003, which was Modern Medical. The first clinic I set up was in Caroline Springs. And then over time, I set up multiple practices. And then, as you said, an exit to Zenitas. I was a director of that publicly listed company from 2016 to 2000. It was taken private in 2018, which freed me up. And then Sachin and I set up Scale My Clinic after that. And since then, we're owners in business excellence, how to get more time freedom, how to get more profitability. And in order to do those 2 things, you need to have a 5-star dream team to work with you. and we've helped over 1,000 owners in the 7 years that we've been open, which is pretty cool. 1,000 ownership groups, and that's a large impact piece. And then, as you said, we've set up GP Hero, which is serving the admin services for GPs, and then GP Bookkeeper, which is offshore accounting services, doing the bookkeeping into general practices, just to make sure that all of those systems kind of run reliably without the need of onshore people to do that work. And that also means that people in the clinic can give better face-to-face care, is what I believe. And so it's all been about general practice, really, and that probably takes me up to today. And as you said, I've had 3 different exits from the clinics, and at this current time, I don't own any practices, which is probably how it will remain for a long period of time.
Fantastic. So for the audience here, what sort of triggered you to exit? Because I mean, I think you sort of took pride in that, didn't you? Like that you owned a practice,
There's
blah, 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 and all that stuff. Yep.
There's a really good book by Bill Perkins called Die With Zero. And I think it's an important book for people to read when they run businesses, or they're just, engaging in any wealth creation. The book talks about, accumulation versus spending phases. And I think I have a really strong stewardship philosophy. None of us own anything forever. You've got to exit at some point in time. Generally speaking, you should exit before you kind of want to. That's my usual rule of thumb. Most people exit too late. And so I've always looked for ways to take a little bit off the table, give it to the next, who I think is the most appropriate owner. And so that's been the driver for me. And also, there is also the attention, no matter how much you own, everything needs time and attention. And so I would rather do less things better than do a lot of things to a lesser degree. And so I feel like after 23 years of practice ownership, I've done enough in that space and probably don't need to continue to do more. And the more that I do will just be helping others succeed in that space.
On that note, what about the family sort of businesses that go from generation to generation, buying the freeholds and stuff? How's your mindset different from that?
Yeah. It's a good question. Look, I think there's pros and cons for all things. I think whenever you have intergenerational wealth that is transferred with the business, and there's some really large examples of this, the Murdoch family, the Sims family in Australia, there's some large examples. It's a little bit like having a monarchy. At some point in time, there's an old saying that you should build your business so as that any idiot can run it, because sooner or later, any idiot will run it. And that's kind of the problem when it comes to family and monarchies. At some point in time, there's somebody who doesn't really want to do the job or isn't temperamentally or psychologically suited to the job. And so I think when you give your kids, and this is just a personal belief, if you're going to give your kids and maybe their kids, the experience of some kind of intergenerational wealth, if it's just money or access to resources, then they can build the lives they want. If it's access to money and resources that is conditional upon them working in the business, then it's a little bit of a prison as well. It's less freedom and more of a prison. And, maybe your network can provide opportunities as well. So I probably look at that a little bit differently. Certainly people that have built substantial businesses and they can create opportunities. I mean, if you're growing up as a kid in the Bezos family or something, I'm sure you've got plenty of opportunities. But from my perspective, I do think that the real benefit is in the support you can give to your kids, of course. And again, the resources just give you more time and more shots on goal, really, in terms of you can take bigger risks if you've got more resources. And if as a parent, that's what you can offer to your kids, obviously with appropriate guardrails around the risk taking, then that's probably as big a gift as you can give them.
Oh, I love that answer. Very refreshing. Yeah. So, sticky questions. What do GPs really think of physios in 2026?
Yeah, I think I've had the opportunity of working with physios, obviously on a referral basis, throughout my whole GP career, and then on multiple occasions working with physios as tenants in the practices. In terms of the frequency of referrals, I think prior to mental health treatment plans, probably the highest frequency recipient of referrals would have been physios. I'm not sure where that stands now. It's probably, pretty similar between physios and psychology for referrals. So that physios have a really good standing in general practice. If you're ever talking about musculoskeletal medicine, I think you would have physios and sports med doctors on a similar plane. So there's no doubt that GPs hold physios in high esteem for good reason. Reputationally, I think physios are excellent. They're very clinically focused. There's not physiotherapy is pretty good in that it's protected from woo. There's not much in the the fish clapping and the kind of weird stuff that goes on in there. It's pretty structured and I think scientific. And so I think a lot of doctors are comfortable and comforted by that. And so I think that professional respect is at a really high level with physios, certainly between GPs and physios. And just in terms of, I'm in some groups that, as you'd expect, like GPs Down Under and things like that in Facebook, with sort of 8 to 10,000 GPs, you don't really hear of any disparagement of physios. And so I think that's a good sign too. People aren't sooking about that profession. They might sook about others, but physios don't come in for any heat, I think.
Oh, that's great to hear from the inside, from the social media groups where it matters, right? What makes a GP trust or even stop trusting a physio to refer to someone else? And you've probably seen it many times.
This is a really good question. I think the answer is professionalism is really the main thing. So, and professionalism is I think multi-layered. One is behaving like a professional, obviously, and so that means that the trust that the patient invests in the physio is not in any way abused or misdirected. And by that, I just mean that people are doing the things that they've been referred for, and that if there's kind of things that are outside of that scope that may be in their remit, that's just kind of a collaboration on that. That's really important. And then I think the second thing is communication. Probably most relationships break down over poor communication. I think that's just a global rule as well as physio to GP. So what you really want is, in an ideal world, you're receiving a high quality referral. And I understand that doesn't always happen for a variety of reasons, but you would ideally be receiving high quality referrals. And I think as a physio, you should be curating your referral list as well, and educating them as to what your expectations and standards are. And then having high standards and living to them, I think, is a really important part of being a professional. And so just making sure that there are regular updates on the progress of the patient. And, I think one of my frustrations would be, say somebody's seen a patient of mine 5, maybe 10 times, and I'm not really aware of any progress reports or any updates. And so when the patient comes in, there's a part of their care that's not visible to me, and patients love it when their clinicians communicate. So there's nothing better than, a patient comes in and you're saying, hey, I noticed Barry's been seeing you for your shoulder. He's updated me that you've made some progress. You've probably got another 3 months to go. He's asked that we do this bit of imaging or something else. And patients love that. What they don't love is when you're saying, oh, I don't really have anything. Can you tell me what they're doing? And they give their version of it. You're like, oh, that sounds a bit strange. You're not quite sure what's going on. So I think the main thing would be communicating any substantial changes and updates. It doesn't need to be a letter each time, but if you're replying to, or if you're updating somebody on care, it's quite reasonable just to say, hey, look, we've taken this person on. This was the referral diagnosis. We think that it's this particular thing for these reasons. Thus far, it's going as expected. They're improving. I expect a full recovery or whatever it might be by this date. I'll update you when anything's off track from that. Something that kind of gives an idea around expectations. And then, in terms of the list-like things, it's probably the scribbled request for imaging, where they're like, oh, we need your signature so this patient gets this thing covered by Medicare. And it's not a collaborative, hey, I wonder if it's this imaging might help us determine this or this.
Yeah.
Just like, oh, the physio said to give you this, CT head or whatever, and you're like, I'm not really sure what this is. And then you've got to play phone tag. No one loves that kind of, like, oh, it's not Barry's day in, call back on Wednesday. That kind of stuff, I think, is where, the standards drop, where we don't have really clear communication. That's probably the main thing.
Yeah, on that note, I mean, I've noticed there's a few startups now that try to bypass the GP.
Yep.
And I'm sort of, on the fence with that. Like, I think I could potentially lose referrals if I don't send them back. But then it's a quicker way of getting it, like a bulk bill MRI scan, which you're probably aware of. What's your thoughts on that? Like,
Yeah, look, I have this philosophy in life that you need to choose your professionals well, and the professionals I think everybody needs. That everybody needs a good lawyer, everybody needs a good accountant. I think everybody needs a good GP because you need somebody who is the holder of the truth for your healthcare. And if you're not having one person that kind of everything is coming back to, then that means you're the GP. What it means is you're deciding what you need and when and from whom. And I myself have a GP. Like I don't act as a GP for myself, and I actually have the clinical knowledge to do that, but I choose not to because it's unwise. Like you lack perspective in what's required. There's a good reason why APRA prevents us from treating ourselves because you just don't have appropriate judgment for what's required. And so I think that when ease replaces judgment, probably in the end, people are going to be accountable for outcomes that they're not pleased with. And I love in business single point accountability. So there's a thing called diffusion of responsibility. There was a really terrible outcome in New York where somebody was murdered in front of a block of flats, and there was something like 100 witnesses, and not one person called it in, not one person called the police. And the reason why no one called it in was that everybody thought somebody else was doing it. And the same thing happens with your healthcare is if you've got multiple people accountable, then nobody is accountable. And so my preference in anything that I'm doing that's important is that there is a single accountable person. I like that being my GP. So I would always go to my GP and say, hey, I've got this particular problem, or I'd like to get this particular opinion on something. What do you think? And then they would run all of it. Now, I know that sounds like I'm talking my own shop, but I think that if we go and use, referral services where it's kind of an invisible person, the person on the back end is not usually a GP. They're usually somebody who's a hospital-based doctor. Effectively, it's just somebody with APRA registration and the capacity to write referrals or scripts. So that means they've got a provider number. But you could easily be talking to a junior doctor, an intern, a registrar who's doing a bit of cash on the side kind of work. And they're usually not a fellowed GP, so they lack the knowledge. Imagine, using a script referral service and asking for a pill, and you're talking to a neurology trainee. That doesn't make a lot of sense that you'd be getting fertility or contraceptive healthcare from somebody who never does it in their workplace. But on the back end of that thin veneer, that's exactly what's happening. It's just somebody that has a pulse, APRA registration, and and the capacity to write these things because they've got prescriber and provider numbers. I would just rather have a relationship with somebody that I know, that I trust, and I've chosen them because of their qualities and their expertise, and I just run everything through them.
Very interesting point. So I wonder, moving forward, whether these things are going to be investigated and regulated more, around some of the telehealth services and bypassing services.
There's already a move towards that. APRA has said that they will be standing in. Again, these things are pretty young businesses.
Yeah.
You'll start to see people start suing for misadventure. A lot of insurers won't cover doctors that do this type of work, particularly when it's outside of their domain. And also APRA are chipping down as well. The usual thing with this stuff, Barry, is the people that are doing it, I find it's that inverse law, right? The doctors that are worried about this kind of stuff aren't the ones doing it.
No.
The ones that are doing it are often a bit cavalier and not aware fully of the risks they're taking. They might be international graduates who aren't fully aware of the rules and regulations. Yeah, I do worry about some of that because they're not likely to be informed by the businesses that are engaging them. And you can be rest assured that the business engages them in such a way that zero blowback comes to the business, that all of that risk is sheeted home to the individual clinician.
I mean, it's good to get that out there because, I've seen some of these job ads as well, and it's very attractive. It's kind of like work from home on your phone. Do you know what I'm saying? Just use your APRA number. Yeah. Use your provider number. Bang.
Exactly.
I'll make it easy for you, right? With AI and.
I've had a couple of mates that are builders and they know that there are people that loan building registrations for a similar thing, right? They get people building under their registration. And again, it's all good until it's not. Something goes pear-shaped and you're the one accountable. I think we're going to find there are a lot of people here that end up in a fair bit of strife with it. And I think rightly so. This convenience over quality, sometimes you might actively choose to make that trade-off, but I think mostly quality is important because I'll be honest, I plan on living a long and healthy life. My job is to do what I can to make sure I contribute to that I don't do anything that detracts from that. And I think that decisions like this, whilst people might make them once or twice for convenience, if it's a recurring habit, you're probably contributing to reduced accountability around your care. And then that makes that person they're the GP, and usually they're not qualified for that.
No, it's good to hear this, even just from a physio perspective, like whether they're engaged, right, with a doctor who's just using their provider number. It's important just to be aware of the kind of longer term ramifications on their own reputation as well, ultimately.
Yeah, I think the same thing is true in the allied health space as well, Barry. People may see osteopathy, chiropractic, these things as being interchangeable services with physiotherapy, and that's just not true.
Yeah, but patients.
Yeah, exactly, because what they see is these people all treat musculoskeletal.
Correct.
And that's what's in their head. But actually the modality and the scientific basis of the treatment is very different. And so again, the frustration you would have if you're accountable for managing somebody and then they're doing 2 or 3 other things as well that you're kind of not aware of. Again, it makes sense to say, okay, well, let's try one consistent and cohesive approach and run it to the point that we're happy we've given it a trial. Not everything works, which is true in life more broadly, and that's okay. But again, things are less likely to work if you're doing 2 things that improve it, another 3 things that make it worse, but nobody's aware of that secret kind of the secret contribution from other practitioners.
Yeah. So question for you. So, I mean, I've had physios try to shout doctors lunch, sushi and all that, to take that diary spot. And it feels, you can correct me, like they're just getting a free lunch. And they're like, you go in there, you do your presentation, all the evidence, here's my program. Where's your referral pads? Blah, blah, blah. You're in our system. I'll refer. I promise to refer.
Yeah.
Good. They eat their sushi and then you don't hear them again.
Yeah.
So what are your tips around that? I'm sure you've heard that one.
Yeah.
And it doesn't just happen to physios, I'm sure. Medical specialists.
Yeah. This is a great question. I think the first question is, what type of practice do you want to run from the perspective of the physio? So a mistake people make is saying that they do everything. Now, if you're a physio, people assume that you have competency in all musculoskeletal work. However, you just need to choose one thing that you're kind of marketing more than others. So I think that makes it easier for people to remember you. You might say to someone, hey, I'm a generalist. I won't knock back any referrals from you that relate to these things. However, if you notice a patient that has shoulder pain, then, or loss of function then I'm the person that has a special interest in that area. And then within your physiotherapy clinic, if you've got subspecialties, some interests that can be triaged at the front desk, that's a great thing to know. I think you need to be choosy about the clinics that you attend, if that's your choice. And it should be larger practices and ideally ones that kind of have a leaning towards what you want. So, for example, there will be clinics that do a lot of sports medicine type work, even though they might be general practices. They're open on, say, Saturday and Sunday to get all of the injuries from weekend sport. Particularly in winter, that's a big deal, with football, etc. And so those places will be higher value to go and talk to them around what they're doing. I think you can easily do lunch and learn where you don't bring lunch. Like, that's okay. You might just bring something that is a goodwill gesture. And the things you leave behind should just leave an indelible mark around what you do and who you serve. And then I think the next thing is just to have outstanding communication that comes back ASAP. If you're going to make a service delivery standard promise, it would be about communication, I think. And again, as you said, it probably isn't the most efficient and effective way to get patients in. But I think even just, having the habit of writing a great letter, ringing GPs from time to time, just to say, hey, I appreciate this referral. Like, I think the dopamine hits that come from rewarding certain pathways are really important.
Yeah, like just a quick personalized call. Yeah.
Yeah. And then you find out over time, the people you like to work with. So we all know this in our working lives, right? You're like, oh, if I get a referral from Barry, I love them because he's worked them up properly.
Yeah.
He's used it on the money with his
Yeah.
diagnosis.
Makes me look good.
Yeah, exactly that, right?
Yeah.
So
Okay.
we all want to work with people who make our lives easier, that they position us as the expert in the space. You're like, you know what? Barry does a lot of this. I'm confident that he'll be able to get some improvement. It's going to take you 3 to 6 months. Don't expect to be better after one visit. They've kind of done the framing work on the back end.
Primed. Yeah.
Yeah. And what you want to do when you get those are the doctors that you want to say, hey, Barry, thanks for the referral. I met John, cracking guy, really enjoyed it. The conversation, we've started treatment. You're going to get a letter in the next week, but I just want to let you know straight away. Now, if you start doing that and your job is to get from 5% of their referrals to 80% of their referrals, that's great. So do the work on those ones. The ones that you don't love, I mean, you still got to have standards around what you communicate and and your communication may include some educational elements around, hey, appreciate you sending this person. If you have the time to do a shoulder examination in future, this is where to start. Now, one thing that I think people should do in all allied health professions, but particularly physio, is, and I used to talk to the physios that worked with us about this, put together a YouTube channel and just make your YouTube channel like the 60-second or 90-second examination for X joint, for this shoulder joint. So, for example, when you send that back to them, that letter, you might just say, hey, I've attached another letter with a QR code, and you can just have a quick look at the YouTube around how to do a 60-second shoulder examination. So you're actually providing educational resources. You're adding value to them, because the problem is, when you say to someone, hey, look, you didn't send any examination findings, you don't know. This person may have just come from a clinic where they just didn't get that type of presentation. And they're sitting there as a GP thinking, bloody hell, I haven't done this for 10 years. I can't remember exactly how to do it. So if you're just like, hey, next time you send them, I'd love you to include your examination findings and your assessment so I know what you're thinking. That would be a reasonable thing to respond with. You're just like, I've taken some time to put together a video for you in our YouTube channel. And if that included a knee examination, like just 30 or 60 seconds of all of these examinations, awesome. All the different tests that you can apply, all of that kind of stuff would be super valuable to GPs. But guess who else finds it? Patients. And when the patients find it, they're like, wow, this person's really cool. They're professional. They're educating other people in their space. So they must be a thought leader. And it would not take long to put all that stuff together.
I love that one. That's gold, mate. So last question. So, I mean, there's always physios renting rooms from GP clinics to get referrals as satellite clinics. I don't think that works that well financially for the physio, for the GP clinic, right? Because they can use, I mean, you probably coach about this around utilization of rooms and stuff.
Yeah.
Does in-house physio in a GP clinic work, or do you generally kind of sublease the whole thing permanently, which I think I've seen more of? And then others have, get screwed over by some GPs that push them out because they're going to, they get a new GP and then they just remove the allied health completely.
Yeah. I think this is a really good area to just make sure that people have good conversations around expectations. Often people just have insufficient conversations around things because as a GP, the challenge is in the general practice, the rooms cost a lot to run because you've got a lot of resources in there. The things that you don't need as allied, you've got a fairly large reception, you've got a nursing team, you've got a treatment room, you've got insurances that are high. There are a lot of costs that go into that. And so the environment doesn't generally support allied health well, in that the cost base is higher than what you would need in an allied health clinic. However, in many cases, it's an excellent place to begin, either a clinic, like a standalone clinic for allied health, physiotherapy in particular, or an outreach, a branch from their main practice, just to try and capture more patients, but also provide in-house care. I've had lots of people that have taken on full-time rooms and been able to fill them and use them well. One thing I love as a GP about having a full-time room is it means that it's theirs to keep and to manage as they see fit. And then people tend to run it more like a business. So if they're off for a couple of weeks on holiday, one of their mates will come and continue to serve the patient population. And the areas from the physio that are really useful are you get to hang out with a bunch of GPs at lunchtime. That's going to help your referrals, and you can cross educate, so you get to understand how other parts of the health sector work. I think that goes both ways, of course, not just one way. And so the collaboration piece is really good. Patients really like it, as in they'd like to know, oh, hey, I know you saw Barry, and Barry had a bit of a chat to me about the progress you're making. He's really happy, but he's asked if we would do this particular test. So I'm going to refer you off. I'll make sure he gets a copy. People like to know you're talking about them in their absence for their well-being. So I think that side is good. And then the other part, like financially, this is where I think it's just a case of, bridging the expectations and making sure that it kind of works for all people at all times. Now, one of the things I say when I'm coaching owners is if you think that you're going to have allied health in the space, for some people, it makes a lot of sense. So, for example, you might have, special interest clinics where you might have they'll look after kids on the spectrum in some general practices, and it makes sense that you would have allied health professionals that support that same avatar, speech path, OT, some physio in there as well. When you have specialized practice and you align yourself with a general practice that does the same thing, then patients coming through the door have a very high alignment with your own avatar. So that's really good. Women's health, this is another one where you might be getting pelvic floor physiotherapy done as part of that. So I think that it really does come back to, are they seeing the type of patients that you want a subset of? And then ultimately the decision on how you engage the room rental is ultimately what's the size of the opportunity for the physio, what's the reasonable amount to be captured by the room, and what's a reasonable amount to be captured by the physio. And that's an ongoing discussion. I think, at the start, it may well be different to what it is 3 or 4 years in. There's no doubt it can win for both parties. Yeah, and then if somebody is going to exit, that's fine if it's whoever's decision, because it can be a good stepping stone and low risk way to build a practice by just starting with somebody else's overheads all being covered. And so I've certainly had physios that have worked with me where they've been in there, run it for 2 or 3 years until they're flat out, and then they've gone and purchased somewhere and relocated and built a full service physiotherapy. And so it's a really safe environment to do that in, because you get to learn a lot while you're there too.
Yeah, that's how I actually started.
There you go.
Yeah, working just from a room, and that's how it works. But yeah, no, thanks for that, Todd. Really interesting insights. And I think, yeah, you do you coach allied health practitioners on these things around GP? No,
we coach only one avatar, only general practice owners.
Only general practice. Nice. All right. So no, that's great. So no, thanks for sharing that, because it gives you an idea now of how physios should approach GP clinics as well, if they do want to look at a rental opportunity and things. And what I think ultimately, it's not just bombing, right? Calling all the GP clinics and trying to get in the room to get referrals, which is probably what's been happening in the past. Yeah, thanks for that, Todd.
A pleasure. Great to see you. Have a great day.
Thank you.
Thanks for having me on the show.
Thanks, Todd.